في السماء وهو السميع العليم اللهم إني أعوذك من البراس والجنون والجذام ومن سيء الأسقام. A very good morning to all and welcome to another chapter of CPC and this time by the medical department. And the topic will be to let it be or not let it be. This is the question. An elderly lady with life-threatening arrhythmias and a compromised ICD. My name is Mohammad Shahrir Said. I'm not a cardiologist. I'm a rheumatologist. But supposedly all physicians must be able and solid whenever we talk about electrocardiograms, and electrocardiograph should be interpreted very confidently by all doctors, not just in the physician world, but everyone. Well, anyhow, allow me to introduce the presenters, and we have a few distinguished persons in this CPC this morning. The presenters will be Dr. Chithambaram Sethuraman, our medical registrar, Dr. Ashik Rafali, our cardiologist and electrophysiology fellow, and the moderator will be Dr. Shawal Faizal Mohammad, our consultant cardiologist in Hospital Chancellor Tuanku Muhriz, Dr. Abdul Raqib Abdul Ghani, consultant cardiologist and electrophysiologist Hospital Serdang, the Azim Pope, plastic surgeon HCTM, and not to mention Dr. Ron Pichai Chokesawat Tanasapul from University Chulalongkorn, Bangkok, Thailand. Now, before we start, allow me to share a short CV regarding two of our distinguished speakers today. Dr. Abdul Raqib Abdul Ghani graduated medical school in 2005 at University Malaya. I might have orientated him last time, and attained his MRCP in 2010. Completed his electrophysiology training at Christchurch Hospital in 2019, and currently acting Malaysian Heart Rhythm Society President and Head of Electrophysiology Cardiology Department at Hospital Serdang. Our distinguished guests today also include Dr. Ron Pichai Chokesawatan Naskul, graduated medical school in 2007 with first class honors at Chulalongkorn University, Bangkok, Thailand. Completed his clinical cardiac electrophysiology training in 2020 at University of Michigan, USA, and currently practicing as consultant cardiologist, electrophysiologist at Chulalongkorn University Hospital. Published numerous Q1 journals on cardiac electrophysiology and awarded multiple grants. This is a very distinguished pair of guests that we have today, and not to mention Datuk Razali Omar, which I did my short stint in IGN at one time, because at that time only we were only allowed. This is probably the last few years where we are allowed posting in IGN. I'm not sure he remembered me because, of course, I'm not a cardiologist now. But anyhow, welcome to see you, Dr. Datuk.
Thank you.
Coming today.
Thank you.
Right, before I let my witness with the mic carry on, I would like to pass the baton over to Dr. Shawal Mohammad as moderator of today's CPC. Dr. Shawal.
Thank you, Professor Shahrir. Kind introduction. Datuk Razali, we are glad to have you here. I think the other panelists are on their way. Yes. So interestingly, now we have Dr. Chitham. Yeah. So in this CPC, you are on the grill, and I'll be the devil advocate grilling you. But don't worry, Dr. Chitham. The main CPC is not to test what you know. It's actually to test your clinical reasoning and also how you dogmatically tackle a case. So without further ado, Dr. Chitham, please present the case.
Okay. A very good morning to everyone. I'm Dr. Chitham, Registrar Medical. So I'll start with the case presentation. So our case is about a 78-year-old Indian lady with underlying hypertension, type 2 diabetes mellitus, seropositive rheumatoid arthritis with interstitial lung disease, and ischemic heart disease with history of percutaneous coronary intervention PCI to left descending artery done in 2010. She was implanted with the single chamber ICD recently as she had multiple ventricular arrhythmia episodes which complicated with a scalp hematoma due to fall at home. During the last admission, she refused for coronary angiogram to evaluate for ischemia. Pre-morbidly, after the fall, she is ADL semi-dependent, requiring assistance to ambulate. However, able to eat by herself and takes care of her general hygiene. She is a non-smoker and non-alcohol drinker. Denies taking traditional medications. She has no allergies to food and drugs. Social history, she is a widow and being taken care by one of the daughters at home. She has good financial and social support by the family members. Her medication list includes perindopril 2 mg daily, glycoside moderate release 60 mg daily, metformin 1 gram twice a day, sulfasalazine 1 gram twice a day, rosuvastatin 20 mg daily, clopidogrel 75 mg daily, and also apixaban 5 mg 2 times a day. So the history of presenting illness. This time she was presented with 1 month post ICD implantation. She complained of multiple chest discomfort preceded by rapid heartbeats for 1 day. She felt the episodes more than 10 times. Family quickly brought her to the emergency department. Assessment at the emergency department. On arrival, she is alert, GCS full, but distressed due to multiple shocks by the ICD. The temperature was 36.7 degrees Celsius, blood pressure 145/70 millimeter mercury, heart rate 85 per minute, SpO2 99% on room air, and DXC was 6.5 millimole. Her lungs on clinical examination noted minimal bibasal, fine crepitations. Cardiovascular examination noted mild pansystolic murmur heard over axilla and left lower sternal edge, and her upper abdomen examination was soft, and no pedal swelling was noted. On inspection of the ICD, as shown in the picture, noted there was a boggy, slight warm on palpation, and no tenderness on palpation, slight serous discharge seen. On further history taking, she had poor appetite 3 days before having the palpitation episodes and drank less water. She felt feverish but not warm to touch. The ICD pocket skin area was becoming darker and there was some discharge coming out. Otherwise, she denied any vomiting, diarrhea, no altered behavior, no loss of consciousness, no bleeding tendency. She was compliant to her medications. So this was her baseline ECG upon arrival to the emergency.
I'll stop you there. Okay. So you presented a case of an elderly lady just inserted an ECD and now it is shocking and non-stop, and there is look like maybe perhaps a pocket infection. Yeah, I just want to ask you, from the history, right, is there anything that you want to query? Is there anything missing in the jigsaw puzzle of the patient? Yeah.
Any antibiotics taken from GP over the time?
Anything else you want to query from the history? Which
any about the hygiene at home, whether about her, do she takes care of her ICD site? Any trauma? Did she takes care of her ICD well?
Okay, Rotita, my question will be very direct. You know, I wonder why the ICD was inserted in the patient. You know, despite you know I know she refused an angiogram, but there's lip rolling she perhaps she have ischemic heart disease, and looks like she opted for medical therapy. Do you think that's the way to go, or do you think we should perhaps fix the coronary first and then put in an ICD? What do you think?
So as per American and also European cardiology guideline, so among the indications, including the ejection fraction, so someone post-MI after 40 days with the ejection fraction of less than 30 to 35 is actually indicated for an ICD insertion.
Another question of mine is, I wonder why this patient is on NOAC, looks like the ECG is sinus. Do you have any comment on that?
She may probably had the paroxysmal AF. Chadwell's, maybe she had a Chadwell score of 2 and above, so which indicated for NOAC previously.
Okay, can you proceed with the ECG?
Okay, so I like to interpret the ECG. So this ECG is a sinus rhythm. There is a left axis deviation. There is a right bundle branch block. On the long lead, noted there's one PVC. Besides that, PR is prolonged, and also QTC is prolonged. So I can conclude that this ECG have features of a trifascicular block, which consists of a prolonged PR, a left axis deviation, and as well as a right bundle branch block.
Why do you think there's T inversion? Looking at it, V1, V2, V3, is that some maybe perhaps ischemia going on?
It's a part of the RBBB. The T wave inversion is a part of RBBB. Changes in the lead 1.
You think it's part of the RBBB?
In lead V1, there's also a possibility she may have a ischemia ongoing in V2, V3, the left anterior descending LAD.
So I would like to say to the audience, don't worry, the ECG, we will have a panel of experts commenting on the ECG. So Dr. Chitham has told me this patient has possible trifascicular block. The QT is prolonged, right? And,
yes.
and RBBB morphology in the ECG.
Yeah.
Yeah, and then the T wave inversion is possibly due to, again, Dr. Chitham, what do you think the T wave inversion is due to?
Because patient have stented to LAD, so the V2, V3 is a territory of LAD, so possibly there's a ischemia.
You think it's an ischemia induced? Okay, all right. Okay, continue.
So this was the cardiac monitoring taken during the tachycardia. So this ECG.
Okay, Dr. Chitham, yes, interesting. This ECG. This ECG was during when the patient was in emergency or in the CCU?
When the patient was in emergency.
Okay, so they got a capturing. So can you describe this ECG and what is the clinical manifestation of the patient during this bout of ECG?
Okay, so on the ECG, I can see broad complex tachycardia, monophasic broad complex tachycardia. Also can see some, I can notice a fusion beat at the beginning, at the second, there's a fusion beats. So towards the extreme right, the morphology of the broad complex tachycardia is changing, which is most likely is a pacing, anti-tachycardic pacing induced. So when patient arrive,
can you describe more of that? Because the morphology do change. There's a broad complex tachycardia, right? And then suddenly the morphology changes to another. Is that like bifascicular VT, or the VT is coming from another part of the heart, or is there something else going on?
So it's in the beginning, there's a VT. However, the ending part, there is a anti tachycardia pacing going on. So the morphology changes.
You could move your marker.
Oh, yeah, here.
Yeah. Okay.
While patient was having a ventricular tachycardia all the way here. So after the detection, it was paced by the pacemaker, by the ICD. So the morphology is changed after the pacing. And all these are the post-pacing monophasic broad complex tachycardia.
Remember this patient has an ICD. Why it changes like that? Why? Do they usually changes like that? Or is it just like the BT, just suddenly change morphology?
Can I just interject, Shawal?
Yes, definitely. Go ahead.
I just want, because Dr. Chithambaram has actually mentioned it, the reason why it changed. The VT was detected by the ICD, and the ICD is trying to stop the VT by applying overdrive pacing. He mentioned the technical term anti-tachycardia pacing, ATP. But what we know in ICU, sometimes when the patient got VT and the patient has got temporary wire, we can use the temporary wire to overdrive the pacing, pace the heart rate at faster than the tachycardia cycle length, and to try and terminate the VT without giving a shock. So, I mean, your question to Dr. Chithambaram, I think he has answered twice.
Yeah, Dato'. Thank you. Actually, I wanted, I know it's anti-tachycardia pacing, but then I wanted him to normalize the word for non-EPs like in the medical student,
But he's using the right term, anti-tachycardia pacing.
Okay, thank you. Thank you, Dato'. Okay, so this is anti-tachycardia pacing. What happened is the ICD detect before it applies a shock, it detects the VTs and it tries to terminate the VT with overdrive pacing. Okay, Dr. Chitham, continue.
Okay, so this is the laboratory investigation of the patient on arrival, the significant ones. The hemoglobin level was 10.5, the total white cell was 8.5, the platelet 250, biochemistry, urea was 7.5, creatinine 65, sodium 135, potassium 3.1, magnesium 0.5, phosphate 0.6, VBG 7.35, bicarb 22.5, C-reactive protein 3.2, high sensitivity troponin 105. Baseline upon previous discharge 800, and then urinalysis, protein, RBC, WBC, all was negative.
So Dr. Chitham, if you look at this, do you want to do anything?
So so this result show that the patient have a multiple electrolyte imbalance, which consists of a potassium, magnesium, and phosphate, as well as a raised CRP level, which suggests there's an ongoing infection sepsis. And also there's a high sensitive troponin, which is supposed to go down, but it's still quite high. So the first thing that I will do, I will correct all the electrolytes, including the first I will start with the magnesium, then I'll go for potassium, and then finally I go for phosphate. So for the CRP, for the infection part, I will start at
okay, Dr. Chitham, basic question. What is the target? You want to correct, right? Correction. Yes. I would totally agree. If I was the registrar while waiting for my consultant, maybe my consultant difficult to pick up the phone, I'll do the simple thing first, is correct all the electrolyte. Can you tell me what your target is for all the correction?
Okay, Dr. Shawal. So basically for the magnesium, I will aim for keep magnesium above 1. And then for potassium, a normal level 3.5 to 4.5, but ideally 4 is better. And the phosphate level approaching normal 0.78 as per our lab. So ideally, I like to keep magnesium more than 1. Potassium slightly higher at 4.
Okay, excellent. If I was the registrar on call, I would do the same, and I would even fast correct the potassium, keeping it 4 to 5. And closely monitor, because there's not much that we can do, right? Okay, continue, Dr. Chitham.
So this was the chest radiograph on arrival, so of the patient. So the chest radiograph shows there is a cardiomegaly, as evident by the ratio, cardiothoracic ratio of more than 0.5. The lung field is fairly clear. There's no opacities seen, no consolidation seen on the lung field. There's no bedwing or pleural effusion seen. So beside that, the ICD can be seen. in situ.
Okay, Dr.
Yeah.
Chitam, why do you think it's an ICD?
So the ICD, I think if I only depend on this X-ray, about the lead, I cannot confidently tell about the placing. Maybe I should have another angle view for me to confidently say that this lead has been in situ.
So how do you know from the lead, this is an ICD, this is not a single chamber, normal, you look at it and then you can say, this is ICD.
This is it's a single chamber. The tip.
Yeah, what is about the tip or the lead? You can move the cursor to the lead, please. Yes.
Yeah.
Yeah. What is it? What distinguishes that from an ICD and a normal pacing, normal pacemaker? I think normal single chamber pacemaker.
So I don't know how to technically say it, but there's in a normal there will only be wires, but there's some in ICD there's the end part is slightly thicker compared to.
What is that called? The end part is thicker. So that's called a coil. And the battery is a bit bigger. Yeah. Looking at this ICD, is normal. It looks like it's a normal position. There is no sexy D-shaped line, but of course, I think in AP sometimes the projection show that it's a bit straight. I don't think there's any wrong placement with the ICD, and there's a coil there. So that's why to the medical student, that's why this is the ICD, and the battery is a bit bigger compared to the conventional pacemaker. Okay, Dr. Chitam, continue.
So about the main issues in this patient, about the discussion. So firstly, what is the differential diagnosis for the presenting complaint? So overall, when see the patient history, physical examination, and also the investigations, so it points towards patient is having a
Dr. Chitam, can you just show us what is your main issue? Can you just tell us? I'll ask the question.
Okay, the main issue is patient is having infected ICD pocket with multiple electrolyte imbalance, and all of this causing a ventricular tachycardia to the patient.
Okay, is that all your issue? So you are the registrar on call, at night, and then this patient came in. So having a recurrent VT storm and very horrible, and family also say that, oh, this is be having pain, and why do you insert the pacemaker? It's causing more pain. Then better you say you're gonna improve his life, but it's pain, and so Dr. Chitam, you are the registrar on call at night, and then you want to call Dr. Ashik, right, for help, right? You are the on-call registrar. Can you summarize? And what you're gonna relay the message before we pass on to Dr. Ali? What you're gonna relay the message to Dr. Ashik? Yeah.
So if I rephrase my words, I'll say patient's main problem is currently having a VT storm, secondary to multifactorial, such as sepsis and also electrolyte imbalance, and possibly an ACS.
So do you think based on those, so what is your initial management? I just want to see your thoughts on how, before you call Dr. Ashik, you tak boleh lah call Dr. Ashik, hello Dr. Ashik, this patient have VT storm, what to do? So we don't want that in our registrar, we want some sort of a management plan from you. Yeah.
So in terms of in view, the main issue is VT storm. I would like to address the VT storm. So among the ways to address is to reduce the VT burden. And we can achieve that by providing an anti-arrhythmic. For the choice of anti-arrhythmic, for this patient, it's not easy because the patient have a prolonged QT. So as far as I know, anti-arrhythmic class 1A, 1C, as well as 3 is contraindicated for a prolonged QTC. So the remaining will be 1B. and I will choose to go for a IV lignocaine.
It's good because, you know, usually some of you guys will start to amiodarone. I have my reservation to start amiodarone in this patient because of the long QT. Yeah. But then again, sometimes I do when the VTs are refractory. Okay. So what else? What else?
Oh, so besides that, after reducing the VT burden, need to treat the underlying cause of the VT storm, which is the one of it is a sepsis. So to after taking a culture to start an appropriate antibiotics, ideally I will go for a cloxacillin or unacin, a penicillin group. And then second, the multiple electrolyte imbalance, correct it, fast correct until the target is achieved. And then finally, for the ACS, likely ACS, I like to start patient on ACS treatment, double antiplated with Clexane.
Okay, that's cover it. So Dr. Chitam, you can rest for now until we call you again for the grading session. So I would now invite Dr. Ashik, who's an excellent fellow of mine, to see to further tell about the case and how we manage the case. The floor is yours, Dr. Ashik.
Okay, let me share another slide here. All right. Okay, thank you for the panelists. Okay, I see Dr. Rakib there has joined us. I think Dr. Pichai has joined us also. Probably can turn on his video. Okay, so I will proceed from the cardiology side of the treatment. Okay. So in summary, this is a 78 years old lady with underlying hypertension, type 2 diabetes, seropositive rheumatoid arthritis with interstitial lung disease, and ischemic heart disease with history of PCI to a lady done in 2010. So after the presentation to the ED, she was admitted to CCU for infected ICD pocket with VT storm secondary to electrolyte imbalance and possible sepsis or ischemia. So previous history, the ICD was implanted a month before, pectorally at the left infraclavicular area. There was no technical difficulty in attaining the vascular access. There's also good ICD lead parameters after the placement. However, as patient was on DOAC and DAPT, as he was treated as non-STEMI with paroxysmal AF, there were hematoma formation post-procedure which resolved on compression. She was discharged uneventfully with a clinic appointment in a month's time. So this is actually the ICD site after the placement. So it's not really bad lah during the discharge. She was discharged well. There was no worsening of the hematoma formation, and the generator is okay, well placed, and the ICD lead is in situ. So, like Dr. Chitam has presented, the acute management in the emergency department, she was started on IV lignocaine for the VT storm as a baseline. ECG showed borderline QT prolongation, which with QTC of 450 milliseconds. And we corrected the electrolytes and dehydration, potassium, magnesium, and phosphate. Septic workup were taken, blood cultures and wound swab, followed by IV cloxacillin for the infected ICD pocket. So during admission in CCU, patient was on continuous cardiac monitoring and telemetry. There were no more episodes of persistent VT or lignocaine infusion, and there was no chest pain in the ward. She was further planned for ICD check coming morning.
So Dr. Ashik, yes. Thank you. Tachik, I'm still not, you know, I'm an interventional cardiologist, right? We like to unclog pipes, right? I'm still wondering, you know, actually why this patient was subjected to an ICD without correcting the coronary, because I'm just worried, you know, there's still blockage in the heart, and you know, that could be ischemia going on, and that could be the substrate of the VT. Can you elaborate on that?
Okay, thank you, Dr. Shawal. Actually, this patient was consulted multiple times for angiogram, but because during the admission, she never complained of chest pain. So the family always questioned us, so why does she need an angiogram to unblock the arteries where she doesn't have any chest pain? Their main concern was the patient had a fall the last admission before, which she injured her scalp with bleeding. And then because she has a high risk fall, their concern is more of the syncope and pre-syncope episode. So, and then because of doing PCI, this patient will be costly, they've opted for the ICD alternative instead. So I think that...
Yeah, thank you, Dr. Ashik. Yeah. So the electrophysiologist has better convincing power than the interventional cardiologist, I suppose, in this case. Okay, go ahead.
Any of the panelists, probably Dr. Rakib, Dr. Razali, or Dr. Pichai, any comments about that?
Yeah. Hello, can you hear me? Can you hear me? Okay.
Yes.
All right. So I have some thoughts on this. I think when you have a patient with recurrent VT, I mean, obviously this patient is already indicated for secondary prevention ICD. I think Dr. Shawal is right to bring up the issue of survival, because normally, I mean, usually when implanting ICD in a patient, we want to estimate or guesstimate the 1-year survival, because those patients probably not benefit from ICD, and it's actually level 3. I mean, you may cause harm if you implant a patient with reduced survival. But anyway, there are recent trials coming out. The recent one, I mean, I just was shared in my group yesterday. It's called the REVIVE trial, where they looked at whether PCI or optimized medical therapy, I mean, which arm would benefit patients with ventricular tachycardia. And they actually found no benefit in patients who had PCI, I mean, so PCI as a sole strategy to reduce the VT incidence, and even affecting mortality and hospitalization for heart failure. So I think perhaps we can go back and read a REVIVE trial. This is recently published in Circulation. So basically, I mean, there's multiple factors when you have a patient with ventricular tachycardia. One of them is already established scar. So if the patient does not have symptoms of angina, even I mean, the scar is already there. The substrate is already set for ventricular tachycardia, re-entrant ventricular tachycardia. And in this study, it's shown that between PCI and optimized medical therapy, there's no benefit in terms of mortality and also hospitalizations. This is my thought.
Thank you, Dr. Rakib. I totally agree with you on that note. Because there's also the REVIVE BCIS trial, which was, I think, published last year, ESC, right? Also, it looks at, other than PCI, it also looks at bypass surgery. And they found out there's no difference between medical therapy and bypass surgery in patients who are asymptomatic, right? Yeah, because this patient is asymptomatic of chest pain, but she is symptomatic of the VT, right? Perhaps, you know, in this day and age where cost, I reiterate that we shouldn't be cost-guided management, but cost governs us. I think perhaps, you know, you are right. Maybe perhaps an ICD first to prevent this VT.
But on that argument, if a patient has ACS, and I mean, you should make all attempts to revascularize the patient, because the longer that you leave the coronary occlusions, then there will be sort of progression of the scar burden from ischemia.
Dato' Razli and Professor, do you have
Dr. Pichai raised his hand just now. What you're saying?
Yep.
Yes, please. Thank you for having me today. I have 2 points to discuss about. The first one is the reason why we need to implant the ICD. I think we got the consult from interventionists all the time, and when the patient comes in with the ACS, but have the sustained monomorphic ventricular tachycardia, because I think the reason why, let's go back to the bottom line. When the patient has the ACS, we usually assume that it should cause the polymorphic VTs as the mechanism from the ischemia, right? But as Dr. Rakib said about the established scar in the heart, usually cause the sustained monomorphic VT. We usually link the monomorphic VTs with the scar. And a lot of times it just comes along together for the ACS patient plus sustained monomorphic ventricular tachycardia. And if we correct the blockage coronary vessel, we cannot guarantee that the sustained monomorphic VT wouldn't come back. So I just try to explain the reason why they implant the ICD in the first place. This might be the cause. And the other thing is when I saw the tracing, when the defibrillator performed the ATP, I wouldn't be surprised if this patient will come back with a syncope, because the VT was very fast. The rate was about 240 beats per minute. And I don't think this patient could tolerate pretty long in that fast VT, especially in that 240 or 260. And just for the idea that I think we probably need more aggressive ATP or earlier ICD shock for the fast VT, because the success rate to terminate that fast monoventricular tachycardia wouldn't be that high. That is the point for me so far. Thank you.
Thank you very much.
Okay, thank you, Kawia. I'm governed by the time. Yeah. Before we go, I would like to get Dr. Chitam back. Chitam, I hope you are not running away.
He's here with me. Okay.
Okay. So Dr. Chitam, okay, Dr. Chitam. So the VT, you know, it was started on lidocaine. VT and now has come down for now. And you have another problem, which is from the case. The problem other than the VT, what is it?
Sepsis and also multiple electrolyte imbalance, as well as ACS.
Electrolyte imbalance settle, sepsis and
ACS cover. We can covering for ACS. Treat for ACS.
Okay, we treated ACS. Another thing. You know what happened to the patient? You show us the picture.
ICD pocket. The ICD pocket.
Oh, okay. So yeah. So what you want to do with the ICD pocket? What do you think?
So I have to refer the patient to a plastic team for their expert opinion on their management of the pocket.
Okay, that's what we did. We referred the patient for the infected pocket to see whether we could salvage the pocket or not, because of the cost issues, and also this patient is elderly. We don't think we should insert another ICD. Without further ado, I would like to invite our plastic surgeon, the handsome Mr. Azim, or Professor Azim, our plastic surgeon, to give his opinion on the infected pocket.
Thank you, Dr. Shawal. Thank you. Sorry. Hello.
We can hear you loud and clear.
Okay. Thank you, Dr. Shawal, for the introduction. I'm not a professor. And thank you to Dr. Ashik for inviting me to be part of the panel. This is my first experience doing such an endeavor. So allow me to share my screen first. Oops. Yeah, okay, all right. So my experience in when I was referred this case by Dr. Ashik, my thought was I was purely on a surgical point of view. As a plastic surgeon, I don't have any prior knowledge of electrophysiology. So that's why my presentation is titled "Subpectoral Implant of Nearly Anything," because that was what I based my management on. So we heard the history already. So this was the picture of the wound which we received that day. All right. So I won't go through the history because it was extensively discussed. So what were the challenges which we saw at that time? Number one is an elderly lady with multiple comorbids. She's on blood thinners. She already had the previous history of hematoma of the ICD, and apparently in the history also she had bleeding tendencies too. So also the dilemma which was brought to me by the cardiologist, Dr. Ashik at the time, was if we remove the ICD, it would cause her to have frequent SVT, and of course following that mortality. And also I was also thinking about if we go would there be any intraoperative accidents, because this is something I'm not very familiar with. And also with all comorbids, she is considered a high anesthetic risk. So the plan of management execution after discussing with the Dr. Ashik was, number one, we want to salvage the ICD, but we want to do this as safe as possible. So we wanted to switch it to a subpectoral pocket. We need to reduce surgery time due to the fact that she has multiple comorbidities, she's high anesthetic risk. And then we need to anticipate for bleeding issues on table because of her blood thinners and also her previously history of bleeding tendencies. And then with anesthesia, I think finally they opted for regional blocks, which I think was a good decision. And did a chest wall block at the time. So I think it considerably helped in this management. And also I needed a cardiologist on standby. Dr. Ashik was there because we had to anticipate a lot of things like arrhythmias mainly. And also I had to have good and proper infection control. So we instituted pre and post-operative antibiotics and instituted also intraoperative washes and irrigations. So this was, as soon as I debrided that wound, this was the hematoma which came out under the necrotic scar. So as soon as we opened up also, you can see it was quite a big chunk. And number two, the pang of the whiff of the smell is just penetrated everyone's nose. And after managing to remove everything, so you can see on the right side, the picture on the right, that's where you can see the exposed implant now. So after cleaning up everything, we did a triple wash with povidone and chlorhexidine. And after cleaning up with saline, we had a final rinse with the gentamicin, trying to keep it immersed there, right? We use a very syringe flushing. So I didn't have any, when I was trying to do the subpectoral pocket, I did not have any intra-op picture. So allow me to explain using this diagram. So I approach at the lateral border of the pec major. Okay, I do have a pointer here. Yep, sorry. Sorry, I'm not used to this. Anyway, on the lateral border of the pec major, I approached there because I wanted to avoid bleeding as much as possible. This is the relatively avascular plane. The only issue there is usually some interdigitations with the serratus anterior muscle. We managed that thankfully quite okay because there was minimal bleeding. And eventually, if you can imagine, after going the side there, we just feed up the underlying muscle. That plane between the pec major and the pec minor is a relative avascular plane also. So we can actually just perform blunt dissection rather than having to cut any vessels. Actually, the perforators on this side coming from this lateral pocket is minimal. All right. Okay. Just as a matter of discussion, since this is a CPC, you see in this picture they differentiate between the clavicular head and the sternal head of the pec major, differently colored there. So if I were if I did not want to approach laterally, I actually slot it in between the two heads, and this is also relatively avascular, although the better one is from the lateral. All right. Sorry, I don't have a pointer over this. So the left picture on the left shows how it looked like after being implanted under the muscle, and then Dr. Ashik helped me make sure that all the wiring was all intact and okay. And then I proceeded to close. On the picture on the right shows the picture where I closed it. So I would like to say one thing. I did not do any trimming there of the skin. I know it looks a bit unsightly. It doesn't look very neat. But in this particular case, we do not want to cut any excess tissue because she already had a history of the skin was friable enough for it to have a scar overlying it. So I wanted to utilize every skin I could, and I do not want to remove anything yet. I figure if in the future she thinks that if she's well enough, she wants to trim it, I can, but not at that current setting because she was not in a stable condition. Okay, and after that, after closing it, immediately I applied this negative pressure wound therapy device. I think by now many doctors, even though they're not familiar with wounds, I think they must have heard of this already, this NPWT, or colloquially mentioned as vacuum dressing. So basically this sponge is overlying directly over the suture lines. The intention is threefold. Number one is it splints the wound together. It holds it together. Number two, it also helps to vacuum out any exudates or any seromas which might occur in between the suture lines. And number three, extensive studies have shown that it is really good for blood circulation and on the wound edges and helps these wound edges to heal well. So in the case of Madam Sinaya, we utilize everything we can, you know. So also we inserted a drain under there into the pocket to ensure no more hematoma. All right. So at the post-op day 10, everything is intact. Everything was good, and alhamdulillah, so she was let go. I saw her 2 weeks ago, and the wound was still doing good, and she looked comfortable. She was sitting up when I saw in the clinic. So that was the end of our encounter with her. And okay. So just to add a bit of value to my presentation today, I did some research on this ICD implants and their pockets. So I found out that the first ICD implanted was back in 1958 in Sweden by a surgeon Senning, and the inventor was Rune Almqvist. It was implanted on a 43-year-old engineer. His name is Ann Larsen. It ran on nickel-cadmium batteries, and it was implanted subcutaneously in the epigastrium, so quite distance away from the heart. So this is the paper, the first documentation of this first ICD implant. And this is the gentleman who received it, the patient himself, and Larsen. And before that, he had frequent Stokes-Adams attacks. And there was one point which amused me, which I thought we'd share, was that apparently that time they optimized his medical treatment with some caffeine and whiskey, right? Okay.
You like that, don't you?
Mana haram. Anyway, okay. So this was the first ICD. This was the first device. It was entirely handmade. It ran on nickel-cadmium batteries, and the dimensions was 55 times 60 millimeters. Sorry, another amusing fact: they actually used a kiwi shoe polish can as the mold of this. So it was based on that kiwi shoe polish can. And for those people, for maybe the younger generation who has not seen this before, this is how it looks like. I mean, okay, right. So on the left is Almqvist, the inventor. In the middle is Senning, the surgeon, and on the right is Larsen, the patient who received this, and he went on to live a long life, I think until his 70s. Okay, so it was considerably a successful surgery, even for a first trial. So subsequently, 3 years later, 1961, there was the first case series written by Chardak, in which he described 15 patients. And this time they encapsulated the implant in a double shell of silicone rubber. And just as a historical perspective, especially in the plastic surgery field, this was also during the time when a lot of surgeons started to experiment with silicone-based breast implants. So it would make sense that they would use silicone rubber because it is slightly, it's not really that inert. Actually, long-term it does cause some contracture, but it was one of the more acceptable tissues, biomaterials for the body. And in this case series also, all were inserted through subcutaneous pockets, and yeah, presumably because of the safety. So out of these 15, 9 were uneventful. Others had infection or electrode failure, but somehow there was no skin erosion at this point. So these Again, this was a diagram taken from that paper, the original paper. So we can see that how far they implanted it to the abdomen. I guess it's because of also the abdomen having a bit thicker skin compared to the chest wall. If subcutaneously, I mean, it might have more subcutaneous tissue there. I guess that was the reason why there was no skin erosion during those early days. So a more recent study, this was in 2020. This was a retrospective review by this Gautam Datta in India. He collected data on 1,096 patients, and for them also only 10% had subpectoral pockets, and out of these 13% had bleeding. So after gathering some literature on that, so after getting literature from both the cardiology journals and also my plastic study journals, so I pieced together this comparison of subcutaneous and subpectoral pockets. So let's go one by one. Number one, subcutaneous is relatively easier, and the subpectoral is relatively more difficult, especially for those who are not very familiar with surgery. Subcutaneous is easier access. For subpectoral, there's an additional surgical step to dissect the muscle. This may vary in difficulty because some of them have some very muscular men who have a lot of pectoral bulk. It might be a bit more vascular, right? So in subcutaneous also, it's less bleeding. Usually can visualize very early on, and then you can stop the bleeding immediately. But for subpectoral, there is potentially more bleeding, again, because of the higher vascular muscle, right? Sorry to cut you, because the time is envious of us. Okay. I hope this is the last slide, Mr. Azim. Yes, this is, yes. Okay, can I continue? Maybe one more minute? Yep, definitely. Okay, so subcutaneous is faster, and the subpectoral, there's additional 15 minutes or maybe more, depending also. And subcutaneous is thinner and more prone to extrusion as opposed to muscle flaps, which are traditionally better when covering implant surfaces. There's more cushioning. Subcutaneous, there's not much of infection resistance as compared to subpectoral. We know that muscle flaps, they have this muscle macrophage feature, in which they are protective against infection. And last but not least, subpectorals are also less contracture in the future. So thank you. My final slide is just showing these two gentlemen. On the left is Sushruta, an Indian plastic surgeon from 600 BC, and on the right is Stephen Aryan, the plastic surgeon who extensively utilized and manipulated the pectoralis major for a lot of procedures in our field. Thank you. Thank you, Mr. Azim. I found out community between breast implant and also surgical device implant there. And 9 out of 15 wouldn't be acceptable nowadays if you have like more than 6 failures out of your 15 procedures. But then again, thank you, Mr. Azim. Very excellent. I enjoyed it. I learned a lot. Okay, because time is envious, we'll go to our next session. I think there's an advertisement by the device company coming up, and we just want to show the participants that the progress of implants throughout the years, and how we have moved so far from the first implant.
Shawal?
Yes, Dato', anything?
Sorry, because I know that there's medical students around. I just, sorry, Dr. Azim, to correct you. That's not the first ICD. Arnie Larsen is first pacemaker. So that... so there's the difference between pacemaker ICD, because I'm just aware that there are medical students and takut nanti they quote first ICD by Arnie Larsen, takut fail exam.
Thank you, Dato'.
Sorry.
Exam ko, Dato'.
That was the best I could get.
Memang tak ada audio ke?
While waiting for the audio, Shawal, can I just make a comment about the?
Yes, go ahead, Dato'. Yeah,
yeah, but because of time constraint, I think I just want to bring up the long QT that was brought up by everyone. In the presence of right bundle branch block, it is difficult to know what is the absolute QT interval. So I think that shouldn't be the ultimate criteria for withholding intravenous amiodarone, which is usually a lifesaver. Intravenous IV lignocaine usually works for an ischemic-driven ventricular arrhythmias. But if it's scar-related, usually IV lignocaine may not be as good. The other thing we forgot to mention in electrical storm, sometimes IV magnesium sulfate works to stabilize the membrane. We do give that even in the presence of a normal magnesium. IV magnesium sedate the patient. IV amiodarone. Sometimes I give double both IV amiodarone and IV lignocaine. So how to measure QT interval is like you look at the baseline with the presence of left bundle or right bundle. The QT interval. We can't use the absolute QT interval, which is 440 milliseconds for male and 460 milliseconds for female. But you look at the percentage increase after you give amiodarone or any of the antiarrhythmic agent. For example, if the patient just now you mentioned 450 milliseconds, which is actually not that long. For female is about 460. If it goes up by more than 25% from baseline after introduction of antiarrhythmic agent, then that suggests that you have prolongation of the QT and should warn you not to continue with the antiarrhythmic agent.
I didn't get you how many percentage increase I thought from
and
the
it's 25%. So in the presence of bundle branch block, there's no absolute value because you know QT interval takes into consideration the breadth of the QRS, right? So it's the QT interval is not just the repolarization phase, it's also depolarization phase plus the repolarization phase. So because the QT interval takes into consideration the QRS, so if the QRS is normal, then yes, QT interval 440 and 460, but the QRS is broad. In this case, right bundle branch block, then it is perhaps not, we shouldn't use the absolute figure. The final one before we have to leave is this question about trifascicular block. I think it was brought up by the presenter. It's trifascicular block based on right bundle branch block, left axis deviation, which suggests left anterior hemi block and a first degree AV block. First degree AV block is not part of the fascicle. So the presence of first degree AV block and bifascicular block is not the criteria for determining that this is trifascicular block. Trifascicular block is intermittent right bundle branch block and left bundle branch block. So the patient comes to right bundle. The next time you do ECG is left bundle. So therefore, right bundle, left bundle means the patient has trifascicular block, or the patient has bifascicular block with intermittent complete heart block. That's the true definition of trifascicular block, not the addition of first degree AV block.
Oh, I really thought I didn't know this because it's always for us is the axis deviation, the prolonged PR interval, and also the presence of RBBB. So actually, when you say that in that way, when you say there's a fusion of the LBB, and that sounds more sinister and more amped to suggest trifascicular.
Yeah, because if you look at PR interval, the PR interval suggests the conduction delay in the AV node, right? AV node is not part of the fascicle. So if you look at the terminology of trifascicular block, it should not include a delay in the AV node. So PR interval is basically AV node. So I think if you want to, because what does trifascicular block means? Trifascicular block means the patient needs a pacemaker. So if you mention bifascicular block plus first degree AV block, you will be putting pacemaker in a lot of patients. Unnecessary.
Yeah, that's why that's true. Yeah, but really, when I look at the symptoms, we get a lot of referrals for this, and a lot of our ED physicians, because they are really good in the ECG, right? And they are referring to our clinic most of this prolonged RBB, and then they say that this trifascicular block, please assess the need for pacemaker, and most of them, I can tell you, is actually asymptomatic, and are kept in the clinic for monitoring.
I mean, if you look at the natural history, bifascicular block, the chance of complete heart block requiring a pacemaker is 1% every year. So at the end of 10 years, only 10% of your 100 patients of bifascicular block will need a pacemaker. So I don't think we should unnecessarily label a first degree AV block in addition to bifascicular block as a trifascicular block. Because if you say trifascicular block, then you know that patient will need a pacemaker. So I think we have to be very careful about terminology. I know it's loosely mentioned as first degree AV block. I'm not sure. Maybe the other panelists, Rakib and doctor from Bangkok, I mean, what do you guys think? Do you accept first degree AV block as part of trifascicular block?
Yeah, so I agree with Dr. Rosali that a lot of times we just to make a definite diagnosis of incomplete trifascicular block. And I think just incomplete trifascicular block is not the indication for the pacemaker implantation, but the best way to approach this kind of a patient, just follow up and try to see if the patient develops syncopal symptoms over the period of time. And the other thing that is very important to me, and thank you, Dr. Rosali, that brought it up, is about a QTC in the pre-existing right bundle branch block. Again, with this patient, I would still go with the amiodarone first and try to follow up the QT interval and see the response after we start the amiodarone. But I have a little bit lower threshold to stop amio, about a 15% increase in the QTC. I think it's arbitrary number because of the QT development. I mean, the criteria when we gonna call someone a long QT, it was developed by the patient with a sinus rhythm, normal QRS complex, and the heart rate between 60 and 80. And the patient, the age of the patient is 40 or above. So it's pretty limited criteria when we validated the criteria for the QTC. And so for those medical students, I think the statement from Dr. Lasali that we should try MEO in this patient, it's the one that I support the idea. That is all from me at this point.
Thank you. And also from the electrophysiological perspective, the prolongation of QT interval with amiodarone is not the same as prolongation of QT interval with flecainide or sotalol. And the reason for that is because of the homogeneity of the prolongation between the epicardial, the endocardial, and the mid-myocardial cells. So I would still, yes, support IV amiodarone for electrical storm and then monitor the prolongation of the QT interval, whether you take 15% or 20%. So whenever you see prolongation from the baseline, that's when you say, okay, now I make a decision, I will stop the amiodarone. So this is very important practical, I suppose, practical consideration when you are, as Shawal says, you are the registrar on call in the middle of the night. You have to have a game plan in your head.
Thank you, Dato'. Thank you. I just wondering from my point of view as an interventional cardiologist, right? You know, I met this patient and then still having storm, and I'm contemplating whether, you know, should this patient be going for an urgent intervention to fix the coronary, or, you know, the next step is a VT ablation, considering if the risk for the patient is small, a younger patient, and any would any of the panelists expert consider that in this patient?
Usually, you don't bring, unlike primary PCI, we don't usually bring the patient straight to the EP lab for VT ablation. Usually, the patient, as in your case, would settle very well with amiodarone, a bit of sedation, correction of the potassium, correction of the magnesium, and, you know, with beta blockers and all that. So usually the patient would settle. We only bring the patient to the EP lab for VT ablation after all that failed, including putting the patient under general anesthesia and ventilate the patient. So which means you go through all these steps, and if all fails, then you go for VT ablation in a patient with this kind of VT, very, very unstable VT, and presumably the EF is very low, has got high risk. Unless you're prepared to do this VT ablation with either ECMO or with the other devices, then you have to be prepared. It's not like doing a SVT ablation or an AF ablation. These are very, very potentially very high risk group of patients. So I think conservatism. And as Dr. Rakib mentioned, the study shows that don't be too quick unless there is definite ACS, not just because electrical storm equals ACS. And I think we the study that Rakib mentioned that was just published recently shows that there's no benefit in going in and opening up the arteries. So unless you see in your eyes, there is definitely ST elevation or ST depression. But if just VT alone, the VT is because of the substrate which was formed 10 years ago, maybe from an MI. And the patient has been very well all these years, and one day it just triggers into a VT. It doesn't mean that VT was triggered by an ACS all the time. The VT can be triggered by anything else. And you can see, I saw the ECG, a lot of PVC. So those PVCs are the one that triggers this VT. So I think, yes, it is part and parcel of what we usually looked at, but I think we shouldn't, like, for example, DAPT was given in this patient plus NOAC. And that was the reason why the patient had the pocket hematoma, right? So we have to now look back. Why was it given in the first place? In the next case that you have, maybe you should be very careful in putting triples, because it's a recipe for disaster. Dual antiplatelets, because assuming that the patient has ACS plus a NOAC because of atrial fibrillation, and then you do an ICD, and then the ICD was done subpectorally. And this is a recipe for the reason why the patient got a pocket hematoma, which resulted in a pocket infection. I think this patient is lucky that we do not need to remove the whole system. In most conventions, and we've had experience before, with due respects to the plastic surgeon, we've had patients when I was in IJN, we did with plastic surgeon from HKL, good job. And a few months later, Dr. Azim, the patient unfortunately came back with another infection. So once you have a foreign body there, no matter how good, like the surgery has been done to clear up all that, because the source of infection is still there, which is the foreign body, which is the battery and the lead. Unfortunately, from my experience, and we had to do twice, Dr. Azim, with the excellent team of plastic surgeon in HKL. They did a fantastic job, but we were so disappointed, and we learned then on that once we have a pocket infection, the whole device has to be removed.
Thank you, Dato'. Good discussion. I think we don't have the advertisement by the device company because the video is not playing. It's okay. Dr. Sheikh, would you like to further elaborate on the case before we?
Okay, I'd like to share the outcome of the patient, the latest visit that the patient had with us about a week ago. Okay, so this is the echo after 5 weeks. So basically, the ICD, there's no features of agitation for the leads. Baseline EF also the same, about 40%, with also TR also same, not worsening. So this is the wound appearance after 5 weeks. So basically, it's well healed. There's no tenderness. But as Dr. Razali said, this is like a short-term outcome. We need to follow up the patient. Probably in a few months' time, hopefully they should not get any infection. By the way, all the cultures are not negative from the wound swab and also from the blood cultures, all negative for any bugs. So hopefully that the patient can maintain without any infection.
Maybe it's not infection, maybe it's just a hematoma. So maybe the patient is lucky. If it was, I know it, Dr. Azim says it's very smelly. Hopefully it's not infection. It's just a hematoma which has just, a very old blood which is smelly. Because if it's infection, then we are in trouble. Or rather, the patient is in trouble. You can see, Dr. Ashik, that the patient is very skinny, right? So I think primarily, and I think that was emphasized by the plastic surgeon, I normally do a subpectoral implant primarily if I see a very skinny patient. This is to avoid wound dehiscent and so on and so forth. And I always tell the guys, usually when we train fellows, we train them how to get the vein and put the leads. But then for the pocket, we usually unscrub and assume that the fellows know how to make the pocket. And I find that when I do box changes and I curse whoever did the pocket, and I say, this is not a pocket. The pocket is not even subfascial. The pocket is in between the fats, and when the patient becomes skinnier, so there's no more barrier between the ICD or the pacemaker and the skin. So we have to be very careful that it has to be subfascia, which means really at the fascia, you have to identify the fascia and then dissect under the fascia above the muscle, or if patient is so skinny like this, subpectoral implant primarily.
Yes.
Thank you. Any of the other panel before we wrap up the session wanna give their comment? Professor Rompichai, all the way from Thailand. Any comments?
Yes, thank you. I think this is a very good point because a lot of times we don't know if it's just a hematoma or infected as just looking from the outside, especially with this kind of the patients. And we have experiences on this kind of the extraction, and we do really appreciate the plastic surgeon, including in Bangkok also. But I think the learning skill that we need to encompass is about trying to teach the fellows to do the subpectoral implantation to lower risk of the infection. And I think the point that we need to discuss from now on is about what are we gonna do in the patients with unprotected from the VTs without defibrillators, because in Thailand, we don't have the wearable device. Actually we have, but we cannot reimburse the device and it's pretty expensive here. And it might cost a lot of resources by just keeping the patient in the hospital for many months to monitor the VTs without defibrillator, I mean internal defibrillators. What I'm gonna do is I might try to put the defibrillator on the contralateral side, I mean the right-sided implant with a subpectoral approach. And that is one way we can send the patient back to the out of the hospital earlier than just keeping the patient in the house. That is the point for me.
Dr. Rakib?
Yeah, so if I may just add,
I'm wondering whether in KKM session, in KKM, you know, how would you manage this? Because, you know, KKM lagi lah susah, financial and, you know, you want to get, I see Serdang deal with hundreds of thousands of patients. and how would you deal with it?
Yeah, so I think I applaud the HCTM team for managing this very bad sort of pocket. You can almost say pending erosion infection, whether it's actually infected or not. So I think this is one of those cases which is very problematic because you have a patient with multiple ICD shocks and VT storm. And as what Rom Pichai mentioned, if let's say the decision was to extract this system, then you need to have sort of an interim device. And we're quite happy to say that we have such a system called the hospital wearable defibrillator. So it's not similar to the vest defibrillator that you see or you imagine, but it's just basically a mobile defibrillator patch with sort of a holster and a mobile small defibrillator sort of in that holster. So that sort of gives us the flexibility of extracting the system, but in a patient with who's intending to mobilize in the ward, and we need to downgrade the patient from an acute unit to the general ward, then this perhaps may provide some interim protection. But anyway, just focusing back on this case, I think recently there was also a publication which describes this strategy of an infected device. So there is a study published from Tel Aviv describing high ultra concentration of antibiotics within the pocket. And basically what they did is they recruited patients with an infected device, but did not, so they excluded patients who had systemic infection, meaning patients with fever, sepsis, raised infective parameters, and patients who had a positive Staph aureus, because we know that Staph aureus is very aggressive and they tend to form biofilms around the lead and also the device, also the generator. So extraction is the way to go. But as an alternative for lead extraction, which is we can say that this is the established way of treating a device infection, as what Dr. Razali rightly mentions, because long term, if you do not do source control, obviously, especially in infections of Staph aureus, antibiotics may not be able to penetrate the biofilm, which clings firmly on the lead and generator. Therefore, the patients will present back with recurrent infections, and eventually you will need to extract the lead. But for those patients without systemic infection and without Staph aureus bacteremia, there is an option where the plastic surgeons may do exactly what Mr. Azim has done. So basically debride the wound, evacuate all the hematoma, and if there's any sort of pus from within the pocket, and basically cleaning the pocket, removing the fibrotic capsule, and then applying vacuum dressing and infusing ultra high concentrations of antibiotics. In this study, they actually managed to avoid lead extraction in about 90% of the cases that they accumulated over the years. So this is what we call a CITA, CITA, which I must say is an alternative for lead extraction. But nevertheless, having said that, I think lead extraction is still the way to go. It is still the primary strategy. But obviously in this patient who is elderly and who's having multiple ICD shock treatment, and perhaps she may not be fit for a second surgery, then perhaps this is an alternative to lead extraction. But lead extraction, I mean, the Ministry of Health, we are coming up with sort of a system where we have a central referral. So for lead extraction, because it's a very sort of a highly specialized and rather risky endeavor, so you need to have a good team who is experienced in lead extraction with lead extraction tools, with the cardiothoracic backup, with plastic surgery and also a wound team. So then you may have better outcomes, better long-term and short-term outcomes for patients who needs device extraction for infected systems. But anyway, in the Ministry of Health, we are still able to manage. But like I said, it's a matter of pooling the resources to a single or two centers with a specific sort of the volume of lead extraction is there, and there's good surgical backup. So this is the way to go.
Okay, thank you, Dr. Rakib. So we are short of time. I would like to thank all for giving their very and very interesting comment about the case. So what I learned from the case in general, number one is amiodarone is safe in patient with long QT from an LBB, RBB, because it's not the channelopathy associated QT. And don't forget to give, as part of your management, to properly give the patient anesthesia. And in this patient with current VTs, you know, it's like when you have your seizures, yeah, refer to NS for general anesthesia and intubate them. And I found that usually help my patient with activity. We also learned that, you know, there is not all trifascial block is the same. There's incomplete trifascial block, and there's the true trifascial block, which need to be dealt with. And Prof. Dr. Aziz said about pocket care. That's for us, for interventional cardiologists, and also for EPs like Ashik to learn. You know, we have to make our pocket properly, care in the pocket. And from Dr. Rakib, we know that there is implantable wearable defibrillators available in Sedang, and KKM is doing a lead extraction team. I think this is something that in UKM we should go into, and it's an important arsenal to have in our management for infected lead. So thank you, everyone. I would like to pass the floor to my professor, Professor Shahrir, for the end note. Thank you.
Okay, thank you. Thank you, Prof. Shawal, Dr. Shawal, for such a elaborate conclusion to the talk. Sorry, I blocked. And we hope that the discussion has been very fruitful, and for from medical student level all the way up to consultant, I think we learned a lot. And you must remember as well that it is also important to know your ECG, and ECG is actually not easy, and hopefully it will be a knowledge that we carry on as long as we are practicing doctors. So thank you all. Thank you, Prof. Ron Pichai, Dr. Abdul Rakib for giving such a good input. My old teacher, Datuk Dr. Razali, for coming in and giving important points, practical points in his lifetime as an AP. And thank you all for coming.
Don't leave first. I think ada
Yeah.
question. Can everyone turn off their camera, and our friend can take the picture photo session.
Depan ni kita ada quizzes quizzes.
Yes. Siapa ni? Ambil gambar dulu. Take our photos together, everyone.
Just a last word to my cardio friends. Kalau ada case boleh refer lagi lah.
Wah, I love that. So,
Boleh.
Okay, 1, 2, 3, smile. Jap. One more. 1, 2, 3, smile. Okay, dapat.
Dah ke?
Dah dapat.